So imagine you're lying on an operating table. The anesthesia is, it's just kicking in.
Right.
You trust your surgeon's steady hands, obviously, and you trust the physical steel of the scalpel. But what if the medical device making those cuts, or I don't know, the machine planning your radiation, is actually taking its orders from an invisible algorithm?
Yeah, that completely shatters our traditional comfort zone. I mean, we are incredibly accustomed to medicine being visible, mechanical. Like you
Exactly.
break a bone, an X-ray shows a jagged white line, a doctor points to it. We like things we can actually see.
We really do. And that is exactly why today we are opening up this massive custom stack of sources you sent us. We are looking at a really complex pile of documents
That's
today.
quite a snack.
It's huge. We've got everything from regulatory guidelines from the FDA and the UK's MHRA to some honestly terrifying cybersecurity reports, and then clinical data covering robotic surgery and even mental health chatbots. And the core mission for our deep dive today is to answer one central question. Can AI-guided treatment planning actually improve patient safety? Or does it introduce entirely new, hidden dangers that we just aren't prepared for?
It's the perfect question. And to really get at the heart of your sources, we have to recognize a fundamental shift happening in medicine at this very second.
Okay, what kind of shift?
Well, we are transitioning out of an era where AI acted as a basic decision support tool. Think of it like a sophisticated spell checker for doctors.
Right, catching minor things.
Exactly. But now we are moving into an era of semi-autonomous decision-making. The stakes are no longer just about um, saving a hospital administrative costs. We are talking about literal biological life and death.
Which is wild. So let's start with why a hospital would even rush to adopt this level of complexity. I mean, nobody installs an invisible, potentially unpredictable artificial intelligence into a life-saving workflow just for, the novelty of it.
Definitely.
When you look at the NHS data in our stack, it really all comes down to the sheer crushing volume of patient need, right? And the promise of unprecedented speed.
Absolutely. The medical system is buckling under its own weight right now. Take the data from the National Institute for Health and Care Excellence, NICE, regarding AI for radiotherapy contouring.
Contouring. Okay, we should probably define that for anyone who hasn't been through it.
Yeah, so contouring is a foundational, non-negotiable part of cancer treatment. Before a patient can be irradiated, a clinical oncologist has to sit at a screen and manually draw outlines around the target tumor volumes.
Right, literally drawing the borders.
Yes, and then they
Yeah.
have to draw separate outlines around the surrounding healthy organs.
Because if you're firing radiation into the body, you want to obliterate the tumor, but you absolutely have to miss the optic nerve or, the
Yeah.
spinal cord or major blood vessels.
Exactly.
And doing that pixel by pixel by hand is painstakingly slow.
It takes immense concentration. It's exhausting. But NICE evaluated AI technologies, systems like Siemens AI Rad Companion or Murata's DLC Expert, which process the patient's MRI or CT scans and automatically generate an initial contour map,
Just like that.
just like that. And the clinical evidence suggests this software can shave anywhere from 3 to 80 minutes off a single treatment plan.
Wow, up to 80 minutes. And we
Yeah.
really need to translate what that means in the real world. If you look at the NHS England data from the sources, there were 134,419 radiotherapy episodes in just 1 year, between 2021 and 2022.
A staggering number.
Right. So if you are saving up to 80 minutes per plan, that means for every single work shift, an oncologist is suddenly handed back enough time to actively treat two entirely new patients.
Yes.
Or, perhaps just as importantly, they get an hour back to sit down and hold the hand of a terrified family.
Which is arguably just as critical for patient care.
Yeah.
And the AI software only costs between £4 and £50 per plan.
That's nothing.
It's highly cost-effective for a struggling hospital, which totally explains why the UK government just injected a £36 million boost into the NHS to fund 38 distinct AI projects.
Oh, right, like Page Prostate.
Exactly, Page Prostate. It automatically analyzes biopsy samples to detect and quantify cancer cells. That directly addresses a massive bottleneck caused by Well, a global shortage of human pathologists.
The sources also highlight Behold AI, which is an algorithm that fast-tracks chest x-rays to spot suspected lung cancer, so patients get a same-day CT scan instead of, waiting weeks in the dark.
The time savings are incredible.
And there's Zebra Medical, which does something brilliant. It acts like a medical detective, analyzing old, existing CT scans in the hospital's database to spot previously undiagnosed spinal fractures.
Right, fractures that point to severe osteoporosis, finding patients who basically slipped through the cracks.
It's amazing, and the application is also pushing heavily into mental health, which is a sector experiencing a massive capacity crisis right now.
Oh, absolutely. The documents detail a digital cognitive behavioral therapy tool called MindBay, which was piloted in GP surgeries.
Yeah, that one stood out to me.
They saw 70% of patients actively engaging with the tool within 48 hours of it being offered.
70% in 2 days. That is huge.
Yeah.
And then there's WISA, which is an AI-powered chatbot acting as a bridge. It gives patients structured self-care exercises while they sit on waiting lists for a human therapist, which, we all know can stretch for months.
Yeah, it fills a really dangerous gap in care.
It sounds like your local clinic is suddenly getting a hyper-efficient genius intern who never sleeps. But I have to play devil's advocate here for a second.
Go for it.
If this system is moving at lightning speed to clear these massive backlogs, doesn't moving that fast inherently increase the risk of rushing a critical medical decision? Like, are we confusing velocity with safety?
That is a completely valid fear. To ease that, we have to look at the mechanisms of how the human-AI interaction is actually designed in practice. One of the primary drivers of medical errors in a hospital is human fatigue.
Okay, sure.
By taking the heavy lifting of raw data processing off the doctor's plate, the AI reduces that cognitive fatigue. The underlying philosophy isn't to replace the clinical staff. The goal is to shift their role.
Shift it how?
Instead of being the exhausted creators of these complex treatment plans from scratch, the radiographers and oncologists become the editors.
Creators to editors.
Exactly. They review the AI's output, tweak the boundaries, and authorize the final plan.
So the human acts as the final safety check. But if their AI is acting as the brain proposing the treatments, I think we need to talk about the hands.
The physical devices.
Yeah, the physical, energy-based medical devices that actually execute these procedures. I was looking through the safety track records of these physical tools and the sources before AI even gets involved, and the baseline reality is pretty sobering.
Surgical diathermy is a perfect example of this. It's a foundational tool in operating rooms globally. It uses high-frequency electrical current to cut through tissue and instantly coagulate blood vessels.
Right.
Modern, minimally invasive surgery wouldn't exist without it because it drastically minimizes blood loss. But the physics of the device carry severe risks.
Yeah, I was trying to wrap my head around this mechanism in our sources called capacitive coupling.
Yes, that's a dangerous one.
If I'm visualizing this correctly, in something like laparoscopic surgery, you have these insulated metal instruments passing through narrow metal or plastic tubes into the body, right?
You're right.
And capacitive coupling is essentially a stray electrical leak. The high-frequency current from the active electrode basically punches through intact insulation, transferring into surrounding conductive tissue.
That is a perfect visualization. It creates a stray current that burns healthy internal organs completely outside of the surgeon's field of vision on the camera.
That's terrifying. So they might finish the surgery and close the patient up without ever knowing they caused a severe internal burn.
Exactly. And your sources point out these high-frequency currents can also completely scramble a patient's implanted pacemaker or defibrillator if the electrical pathway accidentally crosses the chest cavity.
Wow. Which I guess transitions us to an even more hotly debated use of energy-based devices. Vaginal lasers.
Yes. Specifically, fractional CO2 and radiofrequency devices used to treat the genitourinary syndrome of menopause, or GSM.
And the clinical data provided in our SAC on this is incredibly polarized, like completely split.
Very much so.
On one hand, there is a retrospective observational study from Japan involving 826 women who underwent over 2,000 laser sessions. And the physiological results showed real short-term benefits.
Right. Patients reported massive improvements in vaginal dryness and a sharp reduction in pain during intercourse.
Yeah, ultrasound imaging even backed it up by showing a physical, measurable thickening of the labia majora tissue in over 80% of the women they measured.
Yet, when we look at the regulatory landscape in the stack, the authorities are basically pulling the emergency brake.
Right.
The FDA in the United States, along with the Royal Australian and New Zealand College of Obstetricians and Gynecologists, have issued severe warnings against using these exact devices for vaginal rejuvenation.
The FDA actually went on record stating the safety and effectiveness for these specific treatments simply have not been established. They warned of serious side effects like severe scarring, burns, and chronic pain.
It's a stark contrast to the Japanese study.
But I think the most alarming part was the analysis of the FDA's MIUD database, which tracks adverse events for medical devices. The researchers found that while physical burns were frequently reported, a massive underlying root cause of these injuries was a fundamental lack of informed consent.
Patients simply were not told about the known, predictable side effects of the laser before they went under the knife.
It represents a critical breakdown in the human-to-human medical communication process, and this is what I keep coming back to as I read through these sources. If the medical establishment is already failing to properly communicate the tangible physical risks of a literal laser beam to you, the patient, how in the world is a doctor supposed to explain the risks of a completely incomprehensible AI algorithm that even the developers don't fully understand?
That is the crux of the issue.
Yeah.
The physical risks we just discussed, stray electrical currents, thermal burns, those are grounded in tangible physics.
Right.
We can measure impedance, we can build thicker insulation. AI introduces a completely invisible layer of risk rooted in abstract mathematics.
Yeah.
The sources mention future surgical tools, like AI-modulated ultrasonic scalpels that promise to constantly analyze tissue density in real time and automatically adjust their energy output to prevent those exact burns we just talked about.
Which sounds like a miracle on paper.
It does, but it demands that the surgeon unconditionally trust the algorithm to make microsecond decisions. So we have to ask, what happens when the algorithm itself is flawed, trained on biased data, or, actively under attack?
Right. We are stepping away from the physical burns of surgical tools and into the invisible burns of bad code.
Precisely.
And according to the sources, bad code is everywhere. There have been over 10,000 AI-related safety incidents reported in healthcare recently.
It's alarming.
Let's look at algorithmic bias, specifically the care management algorithm mentioned in our stack that was used on over 100 million people annually. Its job was to scan populations and identify patients who needed extra medical support.
And the failure here came down to the proxy variable the developers chose. You see, AI cannot natively understand abstract concepts like illness. It requires quantifiable data.
Right, it needs numbers.
Exactly. Instead of programming the AI to analyze complex, nuanced medical symptoms, they use historical healthcare spending as a proxy for medical need.
Wait, spending? Like how much a patient costs?
Yes. The mathematical assumption was simple. The sicker a person is, the more money the system spends on their care.
But the real world doesn't work like a clean math equation. I mean, historically, Black patients have spent less on healthcare than Meferic. White patients with equivalent illnesses due to long-standing systemic inequities, access issues, and under-resourcing.
Exactly.
Because the AI was only looking at the spending numbers, it tragically underestimated the severity of illness in Black patients by a staggering 26.3%.
It's devastating.
It systematically denied follow-up care to millions of people who desperately needed it simply because it scaled a historical flaw at light speed.
And even if an engineering team manages to build an AI that is perfectly balanced and accurate on day one, we immediately run into a phenomenon called data drift.
Data drift.
This happens because the real chaotic data and algorithm encounters inside a living hospital slowly diverges from the sterile static data set it was originally trained on in a laboratory.
The Epic Sepsis model from our sources is the perfect illustration of how data drift happens. This AI is deployed in hundreds of U.S. hospitals to predict sepsis, which is a rapidly moving, deadly blood infection.
Very deadly.
But when researchers externally validated it in real-world conditions, its sensitivity plummeted to just 33%. It was missing 2/3 of the actual sepsis cases.
We have to understand why that drift happens. A hospital's environment is constantly changing. Doctors adopt new medical billing codes, the demographic of the local population shifts, or, the hospital updates how they enter patient intake forms.
Right.
The AI was trained on a rigid snapshot of the past. When the real-world data format shifts even slightly, The AI's mathematical weights get confused.
And the result was that it generated so many false positives, what the sources call alert fatigue, that exhausted doctors had to review 109 flashing alert flags on their screens just to find one single patient who truly needed intervention.
It just became noise.
Total noise. We see a similar failure in IBM's Watson for oncology. I mean, it cost billions to develop and was supposed to recommend highly personalized cancer treatments, but it ended up giving unsafe recommendations. Why? Because it was trained on hypothetical textbook patient data provided by a small group of experts.
Right, because hypothetical data is clean. Real patients are messy. A textbook might describe a perfect case of lung cancer, but a real patient walking into a clinic might have lung cancer, plus a history of heart disease, plus early-stage diabetes.
Yeah, real life is complicated.
The algorithm never learned how to weigh those complex overlapping comorbidities. This creates what security researchers call validation debt. If you don't continuously revalidate your AI against the chaotic, changing conditions of the real world, that debt compounds in the background until the system catastrophically fails.
Wow, validation debt. Let's take that a step further into the cybersecurity reports we provided, because this is where the vulnerability becomes like actively malicious. We aren't just dealing with accidental drift here.
No, we are not.
53% of connected medical devices currently contain critical vulnerabilities. The Internet of Medical Things has essentially hardwired thousands of new unpatched attack surfaces directly into hospital networks.
We are seeing legacy medical devices running on outdated operating systems that were never designed to be connected to the internet in the first place.
In 2017, the FDA had to recall 465,000 St. Jude pacemakers. The vulnerability meant hackers could theoretically send wireless commands from a short distance to instantly drain the battery.
Or worse.
Yeah, or worse, command the device to deliver unsafe electrical shocks to a patient's heart. Medtronic insulin pumps face similar recalls because a remote attacker could intercept the signal and maliciously alter a patient's insulin dosage.
Those are traditional cyber threats targeting the device's software. When we introduce AI, we open the door to entirely new categories of attack, like adversarial attacks.
Okay, what is that?
To understand this, you have to realize that an AI doesn't see a chest X-ray the way a human doctor sees a picture of a lung. The AI sees a massive grid of mathematical pixel weights.
Okay.
So in an adversarial attack, a hacker alters just a few carefully calculated invisible pixels on that digital medical scan. To the human radiologist looking at the monitor, the image looks completely unaltered.
But to the AI.
To the AI, that faint mathematical noise shifts its calculations just enough to push it over a hidden threshold, tricking the algorithm into flipping a pneumonia diagnosis from positive to negative.
That is insane.
There is also data poisoning. Instead of attacking the finished AI, a hacker maliciously alters the raw data the AI is using to learn. If an algorithm is constantly absorbing new patient files from a hospital network to improve itself, a hacker slowly injects subtly mislabeled files into the system over months.
It's like driving an autonomous car, but a hacker is slowly morphing the digital GPS map over a year until the car confidently drives you into a lake.
That's a great analogy.
Or with an adversarial attack, the hacker literally repaints the physical road signs so the car's cameras get confused and it accelerates into a wall. If 53% of medical devices are already vulnerable, plugging AI into a hospital network feels like installing a loaded weapon and leaving the safety off.
It is a profound structural vulnerability, which is exactly why the top security researchers in your sources are demanding a design principle called algorithmic deferral.
Algorithmic deferral.
Yes. The concept dictates that an AI must be explicitly programmed with self-awareness regarding its own uncertainty. If the data it's receiving is too messy, or if a patient's symptoms fall outside the narrow scope it was validated for, the AI shouldn't just take its best mathematical guess.
It has to stop.
It must actively stop and hand the decision back to a human doctor. Safety doesn't come from the machine being flawless. Safety comes from the machine knowing when it is unqualified to act.
So knowing all this, the bias, the drift, the adversarial pixels, how are governments trying to put guardrails on this technology without completely suffocating the speed and innovation we talked about at the beginning?
It requires ripping up the old rule book.
Yeah.
In the UK, the MHRA, the Medicines and Healthcare Products Regulatory Agency, is abandoning reactive policing for a highly proactive framework based on 5 principles: safety, transparency, fairness, accountability, and contestability.
One of the most interesting tools they are using are regulatory sandboxes. The UK has the AI airlock, and the EU has established AI Mind.
A sandbox is a controlled, isolated environment where developers can unleash their AI systems on real-world medical data, but safely quarantined away from actual patients.
Like a test track.
Exactly. They work directly alongside government regulators to watch how the AI behaves, spotting drift and failures before the software is ever cleared for hospital use.
I was also fascinated by the concept of PCCPs in the sources, predetermined change control plans.
Oh, those are crucial.
If you manufacture a traditional steel scalpel, it doesn't change once it leaves the factory. You get it approved by the FDA once, and you're done. But machine learning algorithms are designed to constantly adapt.
Right.
So a PCCP acts as a pre-approved contract between the software developer and regulators like the FDA or Health Canada. They agree in advance on exactly how the AI is allowed to learn and change its own code in the future, meaning the company doesn't have to halt operations and seek a brand new round of regulatory approval every time the algorithm gets slightly smarter.
It's smart.
Uh.
However, regulators are simultaneously fighting fires
Mhm.
caused by companies blindly trusting this technology right now.
Yeah, this part of the stack was wild.
The MHRA recently caught pharmaceutical companies using AI to write their official GXP inspection responses. GXP refers to the strict good practice quality guidelines required for patient safety.
Right. A company had a serious patient safety impacting deficiency, and they submitted a 90-page response to the government. But they let a large language model write it.
And the AI completely hallucinated.
It fabricated fake regulatory references, cited legal frameworks that didn't exist, and just completely hallucinated data points. It turned what should have been a standard 4-hour review process into a 20-hour nightmare as the MHRA's multidisciplinary team had to untangle the mess.
It's incredibly ironic.
It really is. The companies trying to build autonomous healthcare AI can't even trust their own AI to write an administrative email to the government without hallucinating. It makes you wonder if these regulatory sandboxes can actually keep up, or if government policy is moving at a snail's pace while Silicon Valley operates at the speed of light.
There is a massive friction there, for sure. Regulators are demanding glass box transparency, where they can see the math behind a decision, while tech companies often build black box algorithms that are too complex to decipher.
Right.
But the vital takeaway from your sources is that the ultimate safety mechanism isn't a policy document in London or Washington. The ultimate safety mechanism is the human clinical staff on the hospital floor.
The human in the loop.
The human must always have the final authority to override the machine. The AI only sees the electronic medical record. It only sees pixel weights and blood pressure numbers.
Yeah.
It cannot see the physical nuances of a patient sitting in a bed, how shallow their breathing is, the subtle pallor of their skin, the micro-expressions of pain. If an AI monitor calculates that a patient is stable, but an experienced nurse looks at that patient and instinctively knows they are crashing, the human must override the system.
That makes total sense.
Your sources quote a vital hospital hierarchy, actually. Ask nurses first, doctors second, and if they disagree, believe the nurse. Automation must serve clinical judgment. It can never replace it.
I love that quote. So, to bring this all together for you listening, the reality is, as a patient, you are going to be interacting with these AI systems very soon. You might already be doing it.
Almost certainly.
Whether it's a chatbot evaluating your mental health or an algorithm drawing the contours for your radiation therapy to save your doctor 80 minutes of waiting, the precision and the speed are miraculous. But you have to be an informed, vocal advocate for your own care.
Absolutely.
When you sit in a clinic, you have to ask your provider, are you making this decision based on your experience, or is this the algorithm talking?
It demands an entirely new kind of health literacy from patients and a hypervigilance from providers to ensure they don't fall asleep at the digital wheel.
Well said. But before we wrap up, I want to leave you with one final thought drawn from the deepest corners of the cybersecurity sources you shared. We talk about adversarial hackers, but the reports briefly mention a looming existential threat: quantum computing.
Oh, wow. Yeah, the quantum threat is something security architectures are entirely unprepared for.
In a few years, quantum computers will become powerful enough to instantly crack the current encryption protecting all of our global hospital networks and medical data. A quantum zero-day attack, meaning a software vulnerability that the hospital's IT department doesn't even know exists and has 0 days to prepare for, could instantly compromise every connected device in a facility.
It raises a terrifying question about systemic resilience.
It really does.
If we fully integrate AI into every single life-saving device, and we become entirely dependent on these invisible algorithms, what happens when the screens go dark?
If that network goes down in a matter of seconds, would our highly dependent medical staff even remember how to practice 1990s-style paper medicine to keep patients alive? When the invisible algorithms fail, can the surgeons still rely on their own steady hand to make the cut? Something for you to mull over next time you're sitting in a high-tech waiting room. Thanks for joining us, and we'll catch you on the next deep dive.